Hello, this is week 1, video 1 of cardio. We are going to be talking about A&P and a physical assessment. This is a video that I highly recommend you watch. It helps with the heart anatomy. Some basic information about the heart. Where exactly is the heart located? The heart is actually located behind the breastbone, which is in the center of the chest, not to the left like some people think. Think about when we talk about CPR. We don't tell them to go to the left. It is the chest bone, or the breastbone, sorry. There are different layers of the heart. Epicardium is the outer layer, myo, middle, and then endo is the inner. There are different chambers and vessels in the heart. You have the right and left atrium, which are the top. You have the right and left ventricle, which are on the bottom. Then you have your pulmonary artery, which is off of the right ventricle. You have veins, which come from the lungs. You have the aorta, which is off of the left ventricle, and your inferior vena cava, which is coming from the body. There are 4 different valves in the heart. You have your atrioventricular valves, which is your tricuspid, which is on the right side, and then you have your bicuspid, the mitral, on the left side. The way you can remember is try before you buy or try before you marry. So tricuspid's on the right side, bicuspid or mitral is on the left side. Then you have your semilunar valves. You have your pulmonic, which opens to the pulmonary arteries, and you have your aortic, which opens to the aorta. Your mitral and aortic valves are the ones that are replaced most often. Now let's talk about blood flow through the body. First, you're going to have your vena cavas, so blood is going in here and here. As blood's going in, this is your superior and inferior vena cavas. The blood's going through there. Remember, it's coming from the body, so it is unoxygenated. It's coming in here to the right atrium. From the right atrium, it's going to pass your tricuspid valve down to your right ventricle. From your right ventricle, we're going to the pulmonic valve. Remember, pulmonic is going to the pulmonary system. Then you're coming out, you're going to the lungs. This is going to the lungs. What does it do when it gets to the lungs? We're switching to oxygenated. So, where it comes from, we are going back into your pulmonary veins. Remember, veins are away, so they're going away from the lungs, back into the heart. Back into the heart. Back into the heart. They're both coming over here. So it's going behind the heart, behind over here into your left atrium. So once we get to the left atrium, we are going through our next valve, which is the bicuspid or the mitral. So we're going to try before we buy. Okay, so you're going through your mitral valve. It's going to go through the mitral valve into your left ventricle. From the left ventricle, we are going out to the body. Then this good cycle, it goes through here, through your aortic arch, and it goes back to your body. And then this system starts again. And from your body, it sends it back over here. So you have the blood flow first, vena cava. Second, right atrium. Then it has to pass through that tricuspid valve to the right ventricle, to your pulmonic valves and your pulmonary arteries. Okay, then it hits your lungs. Once it goes through the lung system, and then it's coming back to your pulmonary veins. Remember, veins are away. Left atrium, your mitral valve, left ventricle, aortic valve, your aorta to the body again. All right, now we're going to talk about the conduction system sequence. So first you have to know what conduction means. Conduction is the process by which electricity is directly transmitted through. So how is the electricity transmitted through the heart? That's what we're talking about. First, it starts with your SA node, or the sinoatrial node. This can be found at the top right atrium. It is what we call the pacemaker of the heart. So, pacemaker. Pacemaker of the heart. This initiates the electrical impulse and keeps the heart rate around 60 to 100. Next, you have your AV node. AV node is found at the bottom of the right atrium. Atrioventricular node is the long, is what the abbreviations stand for, and it keeps the heart about 40 to 60. So you have up here 60 to 100. Here you have 40 to 60. Don't laugh at my lovely drawings there. Then you have the bundle of His, which connects the aorta to the ventricle impulses. So the bundle of His, this makes that connection. It's right in there, makes that connection. Then you have your left and right bundle branches. These branches go around the ventricles. And then you have your Purkinje fibers. These are finger-like projections. These keep the heart rate between 20 and 40. So when the heart rate gets this low, this is when patients wind up having to have a pacemaker. Thing to know with the conduction system is both atriums contract and relax at the same time, as well as both ventricles relax and contract at the same time. Some terms to know when it comes to cardiac, especially with your EKGs, is polarization. Polarization is the resting state. You also have depolarization, which is the excitability state. And then you have repolarization, which means they are realigning. Your refractory period is a time during which the cells are resistant to an electrical stimulation. So just some vocab to hang on to until we get further in. Cardiac output. Cardiac output is the amount of blood pumped out of the left ventricle each minute. So this is usually in liters per minute. So what the cardiac output tells you is it predicts oxygen delivery to the cells, and it can determine if the heart is pumping enough oxygen to supply the body needs. A healthy adult normally has 4 to 8 liters per minute. Okay. In order to get your cardiac output, you have to times your heart rate, which is the number of times the ventricle contracts each minute. So this is going to be in beats per minute. And then you also have to have, so you're going to times your heart rate to your stroke volume. The stroke volume is the amount of blood ejected from the left ventricle during each contraction. This is not something we can obtain. This is measured by an internal monitor, but it is in milliliters per beat. Okay, so in order to get this, we'll do an example problem. We have a patient with a heart rate of 78 beats per minute. Okay, and we have a stroke volume of 65. Don't mind my crazy writing. 65 mLs per beat. Okay. Oh, how could we calculate this? Of course, we want to use our dimensional analysis. So we'll make this work real quick. All right, so we're going to do 78 beats. This is really horrible drawing. Sorry, it's 78 beats per minute. Whoops. Okay, so you have beats per minute. Then you're going to do 65 mLs per beat. So now I get rid of my beat and my beat. However, remember we said we normally like it in liters per minute. So we have one more to add. We have 1,000 mLs per liter. So I have rid of that, got rid of that. Here is my liters per minute, so I know I'm done with my calculation. This calculation is going to lead us to 5,070 over 1,000, which is going to equal 5.07 liters per minute. So depending on how close the doctor wants to get, it can be 5.07, 5.1, just 5. If we have any of these questions on the exam, I'll tell you exactly what number, where I want you to round to, or if we're going to round it off. But that is an example of how we would get our cardiac output. Again, remember our stroke volume has to be given to us. So what can affect your cardiac output? There are 3 things can affect your cardiac output, which is your increased preload, an increased afterload, or your heart rate. So what are we talking about? So when we increase our preload, so our preload is how much blood is in the heart before contraction. So if we increase the volume, which means we have more blood in the heart, which means we have to have more blood pumped out. So this is going to increase our cardiac output. Also, another factor is your increased afterload. So your afterload is the resistance that the ventricle must pump against. So the more resistance, that means the less blood will go through. So this is actually going to decrease our cardiac output. So if our preload, increasing our preload, which means we're putting more blood in, if we're putting more blood in, that means more blood must come out. So it's going to increase our cardiac output. If we increase our afterload, and afterload is that resistance, if we increase our afterload, that means the more resistant, that means the less blood we are going to get through. So just think of it as the smaller the hole, the smaller amount that can go through. Another thing is our heart rate. Our heart rate can increase our cardiac output. Now we're going to discuss our physical assessment. What do we look at when we obtain a cardiac assessment? Jot some things down. What do you look at when we obtain a cardiac assessment? Gave you a few seconds. You can pause it if you need a little more time, but let's see if you covered everything you needed to. Cardiovascular disease is actually the leading cause of death in the United States, so assessment is important for your early detection and prevention. So what are some things we're going to talk about? We need to know their health history, which means I need to know their medical history, their family history. I want to obtain demographic data. And what are we talking about when we say demographic data? That's things such as their age, gender, ethnic group. We want to talk about modifiable risk factors. And remember, modifiable risk factors are changes can be made, so that's something they can change. We also need to be aware of non-modifiable risk factors, which means things that they cannot change. What medications they're on. Are they utilizing any illicit drugs? And we need to know drug or food allergies. We need to remember that kidneys and eyes have more damage usually because they have the smallest veins. We also want to look at current health problems. Pain and discomfort. Any kind of pain that goes up the neck and down the arm are usually heart issues. This is why when people come in with chest pain or shortness of breath, it is considered a heart issue until it is ruled out. Dyspnea or dysnionic exertion, orthopnea. This is asking them, how many pillows do you have to sleep on? This is going to tell us how elevated their head has to be. Fatigue, palpitations, edema, how much weight have they gained? 1 liter is 2.2 pounds. So think about someone who excessively just gained 5 pounds. How many liters they have obtained in their body. Syncope, watching for these current health problems, getting some information from the patient. We also want to get their pulse. We want to know the rate, which is you get for 60 seconds or 30 seconds. It is a normal between 60 to 100. You can grade the strength by 0 meaning no pulse, a +1 is weak, +2 is normal, +3 is full, or +4 is bounding. We also need to remember our terminology. Bradycardia is slow and tachycardia is fast. We also want to know our respirations. Remember, our heart is attached directly to our lungs. We send our blood from our heart to our lungs. So respirations can be critical with a cardiac assessment as well. We want to note the rate, rhythm, depth, quality. We want to auscultate breath sounds because crackles or rails are wet sounding lungs, which could indicate pulmonary edema, congestion. So looking at those things, we need to make sure we're looking at respiratory as well. All right, we also want to look at the heart. We're going to auscultate the apical pulse, which you listen at the mitral. Normal sounds, you have an S1 and an S2. The first sound is an abrupt closure of your AV valve, so that LUD sound. It's when your tricuspid and your bicuspid closes. Your S2 is the second heart sound from the closure of the pulmonic and semilunar valves, making the onset of the diastole. The rest or refill stage, which is that dud sound. Here are the 5 areas for listening to the heart. You did this in your physical assessment. You have your aortic, pulmonic, herbs, tricuspid, and mitral. Remember, the mitral is where we listen to that apical pulse. A way to remember them is All People Enjoy Time magazine. So there is just a tidbit on looking at your heart sounds. Here is another image that helps you with the heart sounds, that lub-dub. What I was talking about a few slides ago was your lud or lub. Here, dub are these closing. This determines your valve. This is how you hear the heart sounds, which the heart sounds are caused by the closing of valves. Here are some extra heart sounds. I will let y'all read through them. Biggest thing that we need to know, if you are having trouble hearing the heart sounds, what do? You have the patient lean forward on their left side because it actually brings the heart closer. We also need to look at their general appearance, looking at their skin, looking for signs of cyanosis. Central cyanosis is specifically around the mouth. We want to check their temperature, check the moisture. We're looking at extremities. Are they clubbing? Do they have edema? What's their color? Make sure you always check the fingers and the feet. We can also look for mottling, which is turns purple with spots. It also can result or mean bad circulation. Here's an example of clubbing, which is an abnormal rounding shape of the nail bed. We also want to look at edema and determine if it is pitting or non-pitting edema. Here is a sample of how to stage edema. So 0 plus, 1 plus, 2 plus, 3 plus, or 4 plus, which it talks about how deep they would call each of the pitting edemas. Here are 5 P's of circulation: pain, pulse, pallor, paresthesia, and paralysis. Now let's talk about what changes we see as we age. Atherosclerosis is deposits of lipids and minerals in the walls of the arteries, which is narrowing, which decreases your blood flow, which stimulates clot formation. You also have arteriosclerosis, which is a gradual deterioration and hardening of the artery walls. Elevated blood pressure occurs naturally with age as vessels become flexible. Walls of veins become thinner, weaker, and stretched, making valves incompetent. Decreased cardiac function, which means we have a decreased cardiac output, it's fibrosis of the heart valves, weakened conduction through the heart, which can increase our chance for those dysrhythmias. Here is a concept map about the aging cardiovascular system. Here is your atherosclerosis. You can see a normal vein compared to how that plaque builds up, which can decrease that cardiac blood flow.